Hello, welcome back students. Today we'll begin with yet another topic under chemotherapy, anti-tubercular drugs. So the learning objectives for today's session include first, to study the history and types of tuberculous infection, and second, to classify anti-tubercular drugs as primary and secondary drugs and to study the pharmacology of drugs coming under this classification. Well, as recently as around 70 years ago, tuberculosis infection was considered as a very serious health hazard. But with the invent of chemotherapy, it radically changed the outlook of this disease. The mortality rate, which was falling by only 3% per year around 1900, it fell thereafter by about 15% per year by mid 1950. Somewhere around 1948, this year marked the introduction of a very well-known tubercular drug, streptomycin. Since then, many other important landmarks have been seen with the introduction of ethambutol, rifampicin. The concepts and practices in the treatment of tuberculosis have been radically changed. Now, what is tuberculous infection? This is a chronic infection which is caused by the bacterium Mycobacterium tuberculosis and very rarely sometimes even with Mycobacterium bovis. Now, what happens is even if a normal human being gets infected with tuberculous infection, it remains dormant in the human host for many years because of the normal immunological defense mechanisms, which makes this tubercle bacilli to remain silent. But in an immunocompromised patient, tuberculosis resurfaces back. So, infection of the upper lung is the most common form of tuberculosis. Now, these organisms, they grow slowly, very slowly, and this disease is often chronic. For a long period of time, the mycobacterium dwells in body tissues, and therefore the treatment is also for a longer period of time. And because of this, there are several other problems associated with drug toxicity because long-term administration, definitely the toxic effects of the drugs will be seen, or patient compliance. The patient may not readily be very happy to take the drug regularly because of a number of side effects faced by the patient, or the development of bacterial resistance, which is well known. Now, coming to the types of tuberculosis, there are several types as postulated. Pulmonary tuberculosis generally occurs in younger people, and the non-pulmonary forms of the disease are also prevalent, like tuberculous meningitis or tuberculous pericarditis, tuberculous peritonitis, and tuberculous osteomyelitis. Tuberculous meningitis affecting the brain, pericarditis affecting the heart, peritonitis affecting the covering of the individual organs in the gastrointestinal tract, and osteomyelitis affecting the bone. And also genitourinary tuberculous infection is also present. Well, coming to the classification of antitubercular drugs, they are basically classified on the basis of efficacy, means how well they act, and on the safety parameters. There are two classifications: the primary drugs, also called as the first line drugs, and the secondary drugs, also called as an alternative or second line drugs. In case of primary drugs, now these drugs have very high level of efficacy and an acceptable degree of toxicity. So whenever tuberculosis has been detected in the patient is first started with these treatment is first started with the primary first line drugs in tuberculosis classification. So because of its very high degree of efficacy and acceptable degree of toxicity, these drugs are preferred. Whereas the second drugs, they are alternative to the primary drugs when resistance develops in the primary drugs, secondary drugs are, or when there is some bacterial resistance or patient related factors or because these drugs are generally not preferred, the secondary drugs. Why? Because they have a very low degree of efficacy and high toxicity. So occasionally they are used only because when bacterial resistance develop, or when the conventional treatment has failed, or the patient or some other kind of patient related factors have developed which forces the second line or the of drugs to be adopted. So in such a case only secondary drugs are preferred. So the primary drugs, looking at the list of drugs, we have got isoniazid, rifampicin, ethambutol, pyrazinamide, and streptomycin. These are all important drugs used in the treatment of tubercular infection. Whereas the secondary drugs, which are more toxic in nature and rarely used, are ethionamide, paramino acid, PAS, cycloserine, aminoglycoside antibiotics like viomycin, kanamycin, amikacin, capreomycin, thiacetazole. We have also got drugs like ciprofloxacin and ofloxacin, which we have seen, and corticosteroids. Well, coming to the first drug in the primary class classification, this drug is isoniazid, a very important drug used in the treatment of tubercular infection, also called as INH or isonicotinic acid hydrozide. Now, this drug was introduced in 1952 and is even now the most effective drug for the treatment of tuberculosis. Actually speaking, it is one of the most ideal drug, a very suitable drug, that is, because of its least toxic nature and the most efficacious, and also cost wise also it is less expensive. This drug is having both tuberculostatic and tuberculocidal activity in vitro. The bactericidal effect is exerted only against actively growing tubercular bacilli. So it kills the bacteria only in the log phase, not in the lag phase. So the resting organisms are hardly affected by these drugs. So the mode of action is, now these drugs, the main action is by inhibiting the biosynthesis of mycolic acids. Now these are some agents which are very important constituent of the mycobacterium cell wall of the tubercle bacilli. So when the tubercle bacilli is getting exposed to isoniazid, what happens is, now this drug, it by its active process, it combines with certain mycobacterial enzymes and interferes with the bacterial cell metabolism. So inhibition of biosynthesis of mycolic acid is the main action of these drugs, finally affecting the bacterial cell wall synthesis. Now these strains, most of the strains of Mycobacterium tuberculosis are inhibited by isoniazid at a concentration of as less as 0.2 microgram per ml or less. But the unfortunate thing is resistance is rapidly developed to INH, but there is no cross resistance observed amongst the anti-tubercular drugs. This is a very interesting feature. There is no cross resistance. Like for example, if a drug is resistant to INH, it is not necessary that it will be resistant to the other class of drugs coming under the primary class of drugs. Probably because the mode of action of all these drugs are different, slightly different. Now talking about the kinetics, now these drugs are very readily absorbed from the GIT. It diffuses well into the body tissues, including the CNS. It penetrates into the macrophages so that it is in effective. It is showing its effectiveness against the tubercle bacilli, and then it is partly metabolized by acetylation in the liver. Now, this is one important pharmacokinetic feature with this drug INH, is that now acetylation in the liver occurs in different rates. So people are genetically divided into slow acetylators and rapid acetylators. So we are genetically divided as slow acetylators and rapid acetylators, in which the enzymes in the liver are either activated more to metabolize this drug, or they are less activated. That's why they are classified accordingly as slow acetylators and fast acetylators. Now, depending upon the ethnic makeup, For example, fast escalators like black or Eskimo population, they all come under fast escalators. And slow escalators are like we ethnic Indians and all. Uh, the half life in case of slow escalators is more than 140 minutes, whereas it is less than 80 minutes in case of fast escalators. That means the drug is slowly getting metabolized and it is getting excreted in case of slow escalators. Whereas in fast escalators, the metabolism is very rapid and excretion is also rapid. So, in cases of slow escalating patients, they should be ideally treated with low doses administered. Low doses should be administered and they should be administered less frequently so that the side effects which these drugs produce are mild and nil. So, fast escalators, on the contrary, require more frequent administration of the drug isoniazid. So, talking about the toxicity of these drugs, now these drugs, isoniazid is actually relatively free from the side effects if doses are not exceeding 300 milligram daily. But the commonest effects are restlessness, insomnia, that is lack of sleep, nausea, vomiting, muscle twitching, hypersensitivity reactions, they may occur. One characteristic toxic effects observed with slow escalating patients is especially that of polyneuritis or peripheral neuritis, which occurs at higher doses. And that's why during the treatment of INH, this pyridoxine 10 to 20 milligram on a daily dose is also incorporated in order to minimize the side effects associated with this drug, especially of this peripheral neuritis. Now, apart from these toxic effects, convulsions, psychotic episodes, and agranulocytosis may also occur. 1% of treated patients they develop hepatitis. And in talking about the drug interaction, alcoholic patients on disulfiram therapy they produce acute psychosis like reaction because isoniazid interferes with the metabolism of biogenic amines. And isoniazid also inhibits metabolism of this anti-epileptic drug, diphenyl hydantoin sodium, and may precipitate its toxic effect. Next drug is rifampicin. Next important drug coming under the first line treatment is rifampicin, which belongs to a group of drug called rifamycins. Rifamycins are a group of structurally related complex macrocyclic antibiotic which is obtained from Streptomyces mediterraneae. There are three clinically interesting compounds coming from this species: rifamycin SV, rifamycin B, and rifampicin. Our drug rifampicin is a semisynthetic derivative of rifamycin B. Now, this drug is zwitterion and is soluble in water at an acidic pH, and it is one of a great contribution to the chemotherapy of tuberculosis after the main drug isoniazid. Talking about the antibacterial spectrum, rifampicin has a broad spectrum of activity and inhibits the growth of many gram-positive and gram-negative bacteria, including E. coli, Pseudomonas, Proteus, Klebsiella, and all. They are highly effective against most strains of Mycobacterium tuberculosis and also Mycobacterium leprae. This drug is bactericidal. It's a very classical drug and it is having bactericidal property and acts by inhibiting bacterial DNA dependent RNA polymerase. Now, this enzyme is responsible for converting DNA to RNA and finally to RNA to proteins are formed. So, they are very one important step that is by inhibiting bacterial DNA dependent RNA polymerase. Once this enzyme is inhibited, the RNA synthesis is also inhibited subsequently. So it exhibits selective toxicity because mammalian RNA polymerases are not affected by this drug. That's why it exhibits very selective toxicity only to bacterial DNA dependent RNA polymerase enzyme. Now, this effect is produced at a low concentration of 0.5 microgram per ml. It's highly lipid soluble and diffuses easily through the cell membrane to kill the bacteria. And resistance to this by the bacteria and other organisms may develop rapidly by 1 or 2 steps. Now, this is one of the main reason why in the treatment of tuberculosis, an addition of second drug is essential because of drug resistance that is very quickly developed by the mycobacterium species. Why? Because they grow very slowly, and this drug is a very, it's a chronic disease. It takes time for the bacteria to be killed 100%, and nearly 8 to 9 months treatment of with the antitubercular drug therapy is ongoing with the patient. So because of all these issues, the resistance to these drugs is very common. That's why always in the treatment of tuberculosis, you have minimum 2 to 3 4 drugs in combination so that resistance does not develop. Talking about the kinetics, absorption of rifampicin from the gut is almost complete and is impaired or delayed by food or by concurrent administration of paraminosalicitic acid. About 85 to 90% of this drug is protein bound in plasma. It penetrates well in all tissues, cavities, and all. It is metabolized in the liver by deacetylation and is secreted into bile and may undergo prolonged enterohepatic circulation. Rifampicin is employed in the treatment of primarily in the treatment of tuberculosis, and the dose is around 600 milligrams orally. But it is also used in the treatment of nasopharyngeal meningococcal carrier states or in osteomyelitis or staphylococcal endocarditis. Talking about toxicity, rifampicin does not cause any untoward effects when it is prescribed in the usual dose. But on daily treatment regimens, there are some signs of hepatic toxicity which are observed, which appears to be a transient in nature, mild in nature. And on intermittent treatment, if it is like treated with rifampicin, if the patient is treated with rifampicin, given a break, and then again retreated with rifampicin, that is intermittent treatment, 6 toxic syndromes have been recognized, have been identified. That is, one is influenza like symptoms, flu like symptoms will be observed in the patient, abdominal symptoms, that is gastrointestinal disturbances, respiratory symptoms, difficulty in breathing and all, shock, maybe a fall in blood pressure, renal failure, and thrombocytopenic purpura. So these 6 syndromes occur in about 20 to 30% of patients with serious liver damage. Now, one more interesting part to note is that rifampicin induces hepatic microsomal activity. That means it promotes enzyme induction, and therefore, because of this property, it accelerates the metabolism of several other drugs like estrogens or corticosteroids, sulfonylureas, and anticoagulants. Even the uh, effectiveness of the oral contraceptives, if a woman is taking oral contraceptive, then the appropriate method of contraception should also be changed because of enzyme induction. And one classical feature with this drug is whenever this drug is given to the patient, just to check whether the patient is complying with the drug therapy, the when the drug is being released from the body within the body fluids, it will be colored pink. So that is an indication that the patient is undergoing rifampicin treatment. Even the urine will be pink, saliva will be pink, body secretions are colored pink. So this is a very useful guide to patient compliance with therapy. Well, the next drug under primary class of drug is ethambutol. We have seen with isoniazid, we have seen with rifampicin. Next is ethambutol. Ethambutol, this drug is less active as compared to isoniazid and rifampicin, and this drug should never be used alone because of its bacteriostatic property. This drug should never be used alone. It acts by inhibiting RNA synthesis And 70 to 80% of the strains of Mycobacterium tuberculosis are inhibited at a concentration of 1 microgram per ml. It effectively inhibits strains which are resistant to INH and streptomycin. So this drug is very well absorbed from the gut, having a plasma half-life of 5 to 6 hours. It is concentrated in the red blood cells, and this also acts as a depot for entry into the plasma. About 80% of this drug is excreted unchanged in the urine, and this drug is used for the treatment of tuberculosis in combination with other drugs only because of its bacteriostatic property. Now, ethambutol has a characteristic adverse reaction. Uh, it is consumed in a daily dose of 50 milligram per kg, but in high doses, it causes loss of visual acuity, means the visual perfection is disturbed, loss of visual acuity due to retrobulbar neuritis, loss of color vision, and these effects are generally not reversible. The first sign of ocular toxicity may be blurring of vision, loss of red green perception, and in lower doses, ocular complications are very rare. So, loss of color vision or visual acuity due to retrobulbar neuritis is a characteristic adverse effect of ethambutol. The other effects like rashes, pruritus, joint pain, muscle, nausea, abdominal pain, hallucinations, peripheral neuropathy, hyperuricemia, they are all common with this drug. Our next drug, pyrazinamide, this is chemically related to nicotinamide. It is a bactericidal drug which is very active against Mycobacterium tuberculosis, and it is particularly useful in the treatment of tuberculous meningitis. With this drug, hepatotoxicity is the most common untoward effect, and other adverse effects like arthralgia, anorexia, vomiting, fever, diabetes mellitus may occur. Next drug, streptomycin. This drug has been discussed in detail earlier. Streptomycin is a bactericidal drug for tuberculous bacilli in vitro. Tubercle bacilli becomes markedly resistant to this antibiotic also over a period of time due to mutation. This drug has to be used in combination with the other primary drugs in the treatment of tuberculosis, especially in patients with impaired renal function. Well, coming to the secondary drugs for the treatment of antituberculosis, these drugs are less effective and more toxic than the primary drugs as discussed earlier, and they are primarily used in the treatment of patients when the conventional primary therapy has failed or not tolerated, or when the organism is resistant to the primary drugs, or in infection with atypical mycobacteria. So the first drug is ethionamide. This is a close chemical relative of isoniazid. Again, there is no cross resistance between these two drugs, but it suppresses the multiplication of human strains of Mycobacterium tuberculosis. And ethionamide is rapidly absorbed from the gut, widely distributed in the CSF. But adverse reactions are common, like GI disturbances, anorexia, salivation, metallic taste in the mouth, nausea, vomiting, diarrhea. But peripheral neuropathy, optic neuritis, hypothyroidism may also occur. Next drug, paraamino acid. This is a relatively weak antitubercular drug, and earlier this drug was listed amongst the primary drugs, but now it has been displaced to a secondary status by ethambutol. And this drug is having close resemblance to paraaminobenzoic acid and acts in a similar way to the sulfonamides. How sulfonamides they act, they have resemblance to paraaminobenzoic acid, and they fool the enzymes in a similar way. These drugs also they fool the enzymes and act in a similar way to that of sulfonamides. So it is a bacteriostatic drug to most of the strains of Mycobacterium tuberculosis and acts as at a concentration of 1 microgram per ml. The adverse effects include interference with iodine metabolism leading to goiter and myxedema or hypersensitivity reactions, or other effects like hepatitis, jaundice, hematuria, albuminuria, encephalitis, and other disturbances in the blood elements like leukopenia, agranulocytosis, and all. Next drug, cycloserine. It's isolated from Streptomyces orchidaceus in 1955. Now, this has got a very unique mode of action. This is basically an analog. Analog means it will have structural resemblance. Analog of D-alanine. Now, D-alanine, and this acts by inhibiting the enzyme alanine racemase and thereby interferes with the incorporation of D-alanine into the mucopeptides of the bacterial cell wall. So this inhibition of the cell wall synthesis is responsible for the inhibitory effect of Mycobacterium tuberculosis. So it basically acts by inhibiting the enzyme alanine racemase, which interferes with the incorporation of D-alanine into the bacterial cell wall. The cycloserine is the most toxic of all the second line drugs. Side effects are also observed like tremors, dysarthria, vertigo, confusion, psychotic states with suicidal tendencies and all. That's why it is the most toxic of all the second line drugs. Biomycin, amikacin, capreomycin, amikacin, they are all aminoglycosides again used in the treatment of tuberculosis infection. Talking about capreomycin, this is basically a polypeptide antibiotic which is obtained from Streptomyces capreolus, and it is structurally and pharmacologically related to viomycin. And this drug is toxic, basically toxic to the eighth cranial nerve, leading to hearing loss, tinnitus, and vertigo. So it produces ototoxic effect. Hypersensitivity reaction, liver and renal damage may also occur with this drug. The other drug, thiaacetazone, this is a bacteriostatic drug and effective against both the species of the Mycobacterium. The serious side effects include ototoxicity, hemolytic anemia, agranulocytosis, and erythema multiforme, cerebral edema, and hepatic dysfunction. Other antibiotics like ciprofloxacin and ofloxacin, which have been discussed earlier under antibiotics, are also used in the treatment. Apart from that, another group of drugs called corticosteroids are used in the treatment of tuberculosis, and this remains still controversial, the status of corticosteroid therapy, but they are often used as adjuncts, not as a primary treatment or a secondary line of treatment as such, but used as adjuncts. Adjuncts means supplemental drugs. More particularly in the case of primary fulminating pulmonary tuberculosis. That is tuberculous pneumonitis affecting the lungs. It is also used for treating tuberculous meningitis and pericarditis. So what do these drugs do basically? They will decrease the interstitial pulmonary inflammation. So with this what happens? The gas exchange is improved and there is decrease in pleural or pericardial or meningeal fibrosis. And the other beneficial effects of this drug are that it is antitoxic in nature, it's also having antipyretic effects and anti-anorectic properties. So they are supplementing the effects in tuberculosis patients. So we have seen about primary drugs and secondary drugs. The primary first line of drugs are the first choice of drugs, whereas the secondary drugs are rarely used because of their more toxic potential and less efficacious effect. Next class, we will see about the guidelines, certain chemotherapeutic regimens, and how the National Tuberculosis Control Program guidelines works for the tubercular therapy. Okay, thank you.